Hi, everyone. We're going to wait until 4 o'clock to start our presentation with Dr. Taylor, so just hang tight. While we wait, if you have questions that you would like to have answered, feel free to write them in the comment section below. We will leave time at the end so that you can have questions answered, but keep in mind that these are going to be questions that are applicable to the group and not necessarily to an individual patient. All right, I think we're going to go live. Good afternoon, everyone. My name is Alana Foichter, and I am with the National Ovarian Cancer Coalition, and it is my pleasure today to welcome Dr. Sarah Taylor to talk with us about cancer basics. Dr. Taylor is an assistant professor of gynecologic oncology in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of Pittsburgh School of Medicine. Her academic career focuses on both the day-to-day care of women with gynecologic cancers, as well as on developing and conducting early-phase clinical trials. She works and collaborates with translational scientists within the McGee Women's Research Institute to develop and integrate novel biomarker design and utilization as part of these trials. She is a member of NOCC's Medical Advisory Board and a member of the National Cancer Institute Cancer Prevention and Control Central Internal Review Board. Today, Dr. Taylor will provide a basic understanding of ovarian cancer, including staging and types, how that drives treatment, standards of care, and surveillance. We will leave time for questions at the end, so please feel free to use the comment area below. Keep in mind that Dr. Taylor will not answer any individual medical questions, only those that are applicable to the larger group. Now, I'd like to welcome Dr. Taylor.
Oh, thank you so much for having me today. It's truly a pleasure to be involved with the NOCC. Part of what I do every day is absolutely taking care of amazing women like yourself, but also what I do, and part of why I love what I do, is the educational component of not only teaching medical students and residents and fellows, but also the impact that I can have for women every day and better understanding the disease that they're facing as they kind of walk through this journey. And so what I wanted to do today is to start out very basically and just talk a little bit about what cancer is, and then we're going to go over kind of risk factors. We'll talk a little bit about what exactly ovarian cancer is and how we define that as oncologists, and how that helps us to know what to recommend when it comes to treatment and also to follow-up or surveillance. So thinking very basically about what cancer is actually over 100 different diseases, but the very simple definition would be to say that cancer is a disease that takes over the normal cell's activity and causes it to grow outside of what it should be doing, and it also causes the potential for these cells to leave where they should be and to go other places, and that's what we call metastasis. So when we think about ovarian cancer specifically, the vast majority of ovarian cancers, we don't really know the cause, right? We can study these cancers, we can look at them from a molecular standpoint and say, hey, these are what changes are happening within the cells, but we don't really know what caused it to happen in the first place. There are a subset of ovarian cancers that we know are related to hereditary predispositions, and more specifically, the most common one that we see is when women have a change, or what we call a pathogenic variant, in BRCA. So BRCA, there's two different genes. There's a BRCA1 gene and there's a BRCA2 gene. these genes actually work normally in the cells in your body, and they help to repair DNA. And DNA is what kind of drives us as human beings. It tells our cells what to do. And so when those changes, or what we sometimes call mutations, happen in these genes, DNA cannot be repaired the way that it should be when it gets damaged. And so when it can't repair, it has the chance to go awry, right, and outgrow the normal things that keep it in check. And that is why women, when they carry one of these BRCA changes or mutations, they're at higher risk for developing certain types of cancers. Namely, the two highest risks would be breast and ovarian cancer. When women have a BRCA mutation, they have anywhere from a 20 to 40% chance of developing ovarian cancer over their lifetime. And so what we know is that it's super important for us to understand which women carry these predispositions, not only for them, but also for their family members, because we know that there's ways that we can intervene to help women's families, to help prevent potentially breast or ovarian cancer from developing. There are other, what we call hereditary predispositions, or other syndromes that put women at increased risk for developing ovarian cancer. The next most common one is one that's called Lynch syndrome. This one is more associated with an increased risk for colon cancer and endometrial cancer, and is a less well-known increased risk for ovarian cancer, but still significant. And so when we see women with ovarian cancer, part of our job as oncologists is to make sure that we refer you to genetic counseling and to get your genetic testing done so that we can understand whether or not your cancer may have come from one of these genetic predispositions, not only to help you understand why you may have gotten cancer, but also to help your family members, as I mentioned before. Now, when we look at all of the ovarian cancers that we see on an annual basis, only about 15% of them will be associated with BRCA, and maybe another 2 to 3% will be associated with Lynch syndrome, which means that really the vast majority of ovarian cancers, we still don't understand why they happened. And that can be really scary and really overwhelming. And that's scary and overwhelming for us too, right? We would really like to be able to understand why women are getting these cancers, because we want to be able to not only treat them, but to prevent them. And those are active areas of research. But one of the things I always stress to my patients is, you didn't do anything wrong. And I think that that's really important to hear. So many people, when they get a cancer diagnosis, think, what did I do? What did I eat wrong? What did I drink wrong? I didn't exercise enough. There was something that I did or did not do that caused my cancer. Well, ovarian cancer is not one of those things. You know, we don't have a link with anything from a lifestyle standpoint that said, this is what caused your cancer. And so hopefully if you hear nothing else today, be reassured that you did nothing wrong, and that our goal as oncologists is to figure out why women are getting these cancers so that we can stop that. So one of the next things I wanted to go through was to talk a little bit about the way that we classify ovarian cancers, because there's actually different types of cancers. And we call it all ovarian cancer, but ovarian cancers actually encompass cancers that start in the ovary, cancers that start in the fallopian tube, and cancers that start in the lining of the abdomen and pelvis, and that's called primary peritoneal cancer. When we look a little bit more specifically at the ovary itself, there's actually 3 different categories of cancers that arise in the ovary. And that's based on the different cell types that we see in the ovary. The ovary forms cells that can become any type of cell in the body, and those are the ones that create the egg that women send out every month when they ovulate and get ready to have a baby. Those are called germ cells, And you can develop a cancer in those germ cells. There's support cells around those germ cells, and those are called stromal cells, and you can develop a cancer in those, and those we call sex cord stromal tumors. Or you can develop a cancer from the lining of the ovary, and those cells are called epithelial cells, and it's called epithelial ovarian cancer. Epithelial ovarian cancer is by far the most common type of ovarian cancer that we see. And when we hear kind of big reports about ovarian cancer, it's often in reference to the epithelial type. But there may be women on here today, or you have friends or family members that had an ovarian cancer that was a germ cell cancer or a sex cord stromal cancer. And so I think it's important for us to understand that there are different types, and each of these types is treated a little bit differently. And so it's important for us to understand the way that these cancers behave, because again, it helps us to understand what our recommendations are for treatment. So to make things even more confusing, there are subtypes under each one of those types that I just mentioned. I'm going to talk a little bit more about epithelial ovarian cancer just because that is the most common one, but I'm more than happy to answer questions about the other types if people have questions about those. So when we talk about epithelial ovarian cancer, our pathologist colleagues give us more information about the cancer by the way that it looks under the microscope. So they describe those cells to us, and that gives us our subtypes. And our subtypes of epithelial ovarian cancer are called serous, endometrioid, clear cell, and mucinous. And it's all based on the way they look. The way that we describe, or the word that we use to categorize those, are called the histology. So when the pathologists look at it, they give us the histology, and they tell us which of those subtypes. This is different than grade or stage. So when they look at it, they describe it to us. They say this is an epithelial ovarian cancer, it is a serous type, and then they give us what's called a grade. So not only when they look at the cells and they tell us how they appear, they also tell us kind of how ugly they look. So each of these cell types looks similar to a normal cell in the body. The serous cells look like normal lining to a fallopian tube. The endometrioid cells look similar to normal lining of the uterus, or what we call the endometrium. The clear cells look similar to the lining of the kidney. And the mucinous cells look similar to the lining of the GI tract. And what they do with grade is they say, how close do they look to those normal cells? And if they look pretty close to the normal, then they'll call that a grade 1. But if they look really different from, right, they look just like sheets of ugly, angry tumor cells, that's what we call grade 3. And so we talk a little bit about the aggressive nature of it. And with grade 3 cancers, they tend to divide more quickly and be more aggressive. Low-grade cancers, those ones that look more similar to the normal cells, tend to divide more slowly and behave less aggressively. And I use tend to because every cancer is a little bit different, and every woman experiences cancer a little bit differently. And so we use these broad categories to better understand the cancers, knowing that each cancer has its own kind of path, and we don't always or can't always predict exactly what the cancer will do. All of this to say that we have another form of classification that we have to understand beyond where did this cancer start, what does it look like, is where has this cancer gone? And that's what we call the stage. So stage for almost every single cancer is similar in that early stage cancers represent cancers that are just where they started. So for ovarian cancer, if we don't see cancer cells outside of the ovary, then that is a stage 1 cancer. And then each cancer has a semi-predictable way that it spreads. And for ovarian cancer, when it spreads to the things that are next or kind of closest to it, right? So the next thing that it tends to spread to is the fallopian tube. So the fallopian tube sits right next to the ovary. And the next place it will spread is to the other organs in the pelvis, things like the bladder and the last segment of the bowel. And so that's what we call stage 2 cancers. Once it leaves the pelvis and goes into the upper abdomen, up where near the liver or the stomach is, if we see disease up there, then that's a stage 3 cancer. And for cancers that leave the abdominal cavity and go elsewhere or invade into some of the organs, namely the liver, in the abdomen, that's what we then classify as a stage 4 cancer. And so stage gives us another piece of information about these cancers. It tells us where those cancers have traveled or where they have metastasized. And that also helps to guide treatment recommendations. So treatment for ovarian cancer is primarily to remove it if you can, right? And that's done through surgery. But we know that surgery in the vast majority of cases is not enough. There are some early stage cancers where chemotherapy does not have an added benefit, which means it doesn't improve survival or it doesn't decrease risk of recurrence. And we also know that chemotherapy comes with a lot of side effects or toxicity. And so we try to reserve it for where we know it will improve survival or decrease risk of recurrence. And for most ovarian cancers, after surgery is done and the cancer is removed, or in some instances when the cancer can't be removed, chemo is indicated. So we give chemo after surgery if surgery can be done to remove all visible signs of the disease. In the event where we can't do surgery and remove all visible signs of disease, or surgery would be so extensive that it might make you so sick that you couldn't get chemo, sometimes we'll start with chemotherapy first to help shrink the disease to allow us to be able to do surgery safely. Because for most of these cancers, the best chance of a cure, you need both surgery and chemotherapy. Sometimes patients will ask me about the role of radiation and also what the difference is between radiation and chemotherapy and why we use chemotherapy for ovarian cancer. So very basically, chemotherapy is a drug that helps to kill rapidly dividing cells, right? And that's what cancer is doing. It's rapidly dividing. And so most cancers require us to give some form of treatment that is going to get to all of those potential cancer cells. And for most ovarian cancers, they've left the ovary, and so we need to be able to get to all those cells. And so chemo is what we call a systemic treatment, which means either you're going to take it as a pill form or you're going to get it in the IV, and so it gets circulated to all the cells in the body, with the hopes that if this cancer has already metastasized, that we're catching any of those cells that we may not have been able to see at the time of surgery. The difference between that and radiation is what we call a local treatment. So it is literally beams that get shot to the tumor or to the tumor bed, and so it's meant to go to a very specific area. And because ovarian cancer tends to spread kind of all over the abdomen, we don't use radiation therapy that often. And that is because radiation has to take into account that there are healthy organs around the tumor. And you have to be able to get a high enough dose of that local treatment to kill tumor. But if you go too high, you can damage the normal, healthy tissue around it and potentially do damage to those organs that you may not be able to recover from. And because ovarian cancer tends to spread all over the organs in the abdomen, radiation has a limited role in the treatment of this cancer. And then lastly, I'm going to go over a little bit about follow-up and surveillance, and then hopefully get into some of your questions. So our goal, obviously, is to get you to the point where you have no evidence of disease, right? You get through chemo, you get through surgery, and we get that CT scan, and we say there's no evidence of disease. You get to ring that bell, and then we go into surveillance. And what we mean by surveillance is that, particularly with epithelial ovarian cancer, and particularly when we have those later stage cancers, stage 3 and stage 4, while we can get most people to the point where we don't see any disease on CT scan, the vast majority of women will experience a recurrence of their cancer. Their cancer will come back at some point. And so it's our job to keep a close eye on you so that we find that cancer early where it's still treatable with the therapies that we have. For ovarian cancer, this is often done through visits to the office with your oncologist, a physical exam, asking you about how you feel and what symptoms you may have. It may also be done with a tumor marker. Most commonly, that tumor marker is blood work. It's called a CA-125. It is a marker that can be monitored through the blood, and for some women, that marker is elevated or high at the start of their cancer and then comes down when we treat the cancer. And so we can watch that, and often that number will go up before we feel something, right, as patients, before we notice a change, or before sometimes we even see something on CT scan. Not every patient has a CA-125 that they monitor, and it's super important to talk to your oncologist because it is something that can be very helpful, but there are drawbacks to it as well. So we know that there are lots of other things that can make that number go up, things like a pneumonia, like a lung infection, things like people who have liver disease or what we call cirrhosis, even for women who are still getting periods, and that's not most of our patients, but that can make it go up. So there's lots of things that can make that number go up. And so what I stress to my patients is if we choose to use that as part of your surveillance, it is not the only thing that we will use to help guide us as to whether or not we need to restart treatment at some point, because it can go up for other reasons. We also have research that tells us that if we start chemo just based on a rise in that number, that it doesn't necessarily improve survival over time. And so it's a really important conversation for you to have with your oncologist about whether or not it makes sense for you to restart treatment if that number goes up. The other thing that we will use is CT scans. And a lot of the times we're not doing CT scans routinely for a similar reason. We don't want to expose you to a bunch of tests if it's not a test that's going to help us to prevent recurrence or to improve survival, because each of those tests comes with potential risk, right? You can have a reaction to that contrast medicine that we put in your IV. You're getting radiation every time we give you a CT scan. And so as oncologists, it's our job to use these tools to hopefully diagnose, and if it does come back at an early point, but also not to put you through a bunch of tests that you don't need. And so often this becomes a very individualized conversation with your oncologist, because as I mentioned from the very beginning, everyone's experience with this cancer is a little bit different. And I'm sure that you've had many conversations with other women who have gone through a similar treatment, and you share many common things, but you also have many unique things. And so it's important that we know that every individual has a different experience, and that we make sure that we tailor the conversation and the treatment to each person.
Wow. That was a lot of information in a very short amount of time. That was fantastic. Thank you. And so well said. We do have a couple of questions. A lot of them are about maybe terminology. And then there's some that are more about procedures too. So, for instance, someone asked, can you explain what the Omentum is?
Oh, sure, absolutely. So there would be no reason that you would even know that this exists. I don't think I even knew it existed till I got to medical school. So what the Omentum is I tell people it's like a fatty carpron or an apron that hangs off of your bowel. So it's literally attached to the lower part of your stomach and to a portion of your large bowel or your colon. So your large bowel forms this like semicircle around your abdomen, right? So if you touch your right side, your colon goes up your right side, then it goes across the top part of your abdomen near your stomach, and then it goes down your left side. And so the Omentum hangs off of that part that goes across your abdomen. And the best way I can describe it is it's like an air filter for your abdomen. And so it's this fatty tissue, and its job is to filter things. So it helps with filtering the bad stuff. It also helps to wall off infections. So if you've ever known somebody with a ruptured appendix, when we go in there, we actually find the Omentum plastered over the appendix because your body's trying to wall it off.
Okay, so that makes sense then why some people have their cancer spread to the Omentum.
So the Omentum is fatty, and it's filled with a lot of blood supply, and so cancer loves it because fat is a great form of nutrition for the cells, and it also brings lots of oxygen, which the cancer needs to grow as well.
There was another question, and I don't remember you mentioning this, but there was a question about, let's see here, what does Müllerian mean?
Yeah, that's a great question. That is an all-encompassing term for your gynecologic organs. So that if we say Müllerian in origin, and that's a term our pathologists often use to communicate to us, that can mean that it started in your tubes, your ovaries, or your uterus.
Okay, good to know. A couple questions about HIPAC. Can you explain what that is?
Sure, absolutely. So we didn't talk really specifically about different chemotherapy regimens, but in general, when we treat ovarian cancer, the standard of care includes a platinum-based regimen. And so usually we give chemotherapy after surgery. Sometimes we give it before. And more recently, we have looked at giving chemotherapy during surgery. And so this literature actually started in low-grade appendiceal cancers, but has been expanded to other different cancer types. And the way it works is when we take you to the operating room and we do your surgery to remove your cancer, we actually bring a perfusionist into the operating room. We heat up the chemotherapy, and we actually put the chemotherapy into your abdomen while you're asleep on the table. And so we close the incision back up again, and for 90 minutes, we circulate that hot chemotherapy through your abdomen. And what we know is that chemo can work directly on cancer cells, which is why sometimes with ovarian cancer after surgery, we put a port into the abdomen and give chemo into the abdomen. And so this stems from that. And by heating it, we think that it helps to activate the way that the chemo works on damaging the cancer cells.
That was great. And you actually touched on another question, which of course was thoughts on IP, intraperitoneal, along with IV.
Yeah, so we have good data that if we can safely give chemo into the abdomen, it does improve women's survival for a subset of ovarian cancer patients. The patients in which this was looked at or tested in from a trial perspective were women who had stage 3C, so they had cancer that had left and gone into the upper abdomen, but underwent surgery first and got to the point where they had what we call less than a centimeter of residual disease. So you have, if there's anything that is visible left, it's no bigger than the tip of your finger. And so we know that chemotherapy that is put directly into the abdomen can penetrate those tumors, but can only penetrate so deeply, which is why we think it works better when you have really small amounts of cancer left, either microscopic or if there's something that's visible, it's really tiny. So in that patient population, when we compared it to just getting IV chemo, they had better survival. The hard part with intraperitoneal chemotherapy and why you don't see it kind of used all over the place and in all practice settings is that it also has a lot of side effects. So it can make women really sick. In that same trial, the goal was to get women 6 total treatments or 6 cycles. And on average, the women who got that chemo into the abdomen only made it through 4 cycles because of side effects. And that is, you know, it's definitely a double-edged sword. It tells us that even though on average they got less chemo and did better, they also had a lot to deal with, so much so that they said, I can't do this anymore, right? Or their doctor said, nope, not anymore. This is just too much. It's not safe for you anymore. And so it is not for everyone, because the goal of a cancer treatment absolutely is to get rid of your cancer, but this has to be balanced against the fact that if we give you such bad side effects from your chemo that you are debilitated and cannot live your life, then we haven't done our jobs either.
Appreciate that. That's a good point. We have a question that his mother had died of ovarian cancer 15 years ago, and would you suggest that the daughter or the granddaughter be tested for a mutation such as BRCA?
So we do have some data to say that if, you know, particularly before we started routinely doing testing, and also it depends a little bit on family history. If there are other patients or people in that patient's family who had other associated cancers, then absolutely. It's definitely worthwhile to have a conversation with your doctor, and at the very least, you could make a referral to a genetic counselor, and that genetic counselor can take a detailed family history and talk to you about whether or not they think that testing is warranted before actually putting you through the testing or the cost of the test.
We have a lot more questions. I'm going to only ask you 2 more, if that's okay. Thoughts on oral chemos or PARP inhibitors?
Yeah, okay, absolutely. So PARP inhibitors have really revolutionized our field in the last 5 or 6 years. The way that those drugs work is that we talked a little bit about how in ovarian cancer, particularly in women with BRCA, how sometimes we have changes that happen in these cancers that make it hard for the cell to repair DNA damage. And so what this drug does is it takes advantage of that. So there's different ways that our body can repair when we have DNA damage. BRCA 1 and 2 in particular are involved in a pathway, I'm going to use some big words here, but hopefully stick with me, called homologous recombination. And so when those aren't working, your cells rely on other or alternative pathways to repair DNA damage. One of those pathways is called base excision repair, and PARP is a protein in that pathway. So if we knock out two pathways to repair DNA in these cancer cells, then those cancer cells start dying. And so that's the way these PARP inhibitors work. And that's why all of the data that is coming out, the patients that seem to derive the most benefit from this drug are those patients who have BRCA mutations, either in their tumor or ones that can be passed along. They're called germline. But what we're seeing is that even if you don't have one of those changes or mutations, there is still benefit to these drugs. We're still learning about them. It's still very much in its infancy. We're waiting for more data to come back to help guide kind of when we should be using these drugs. Should everybody be getting them? Should just certain patients be getting them? Because just like any other cancer-directed treatment, they do come with side effects or toxicity. And so as we get more information, it will help us to better understand when to use them. Right now, I think that there's a role for almost every woman with ovarian cancer to get a PARP inhibitor at some point. The question is, when should we use them? And that's what we're still trying to understand.
Great. One very quick question, and then I'm going to let you go. Is the HE4 blood test an effective marker?
So there is some data, and I would say that marker has been used as part of a test to help general gynecologists understand whether or not they should be sending certain patients with masses on to oncologists. And then there's also some data trying to use HE4 in combination with CA-125 or in combination with pelvic ultrasound as far as a screening test goes. We don't have any good data that tells us exactly the best place to use that yet. We don't have any good screening tests. We're still working on that, and HE4 may play a role in that, but is not something that is routinely used.
Okay. Well, on behalf of everybody, I think there was a wealth of information here, and I'm sure that there's going to be many people who are going to go back and review this over and over again. If we didn't get to your questions, we may send some on to Dr. Taylor to answer later in the chat underneath. So thank you so much for your time today. I just want to remind everybody who's watching that we are continuing our Ask the Experts series, and we are doing them throughout May and June, and certainly after that. So check our website, ovarian.org, and this Facebook page for updates. Just so you know, the next one will be on May 16th, and we are excited to have Elle Simone of America's Test Kitchen and the founder of She Chef do a immune boosting cooking demo for you. And if you don't know, she is also an ovarian cancer survivor herself. So thank you very much, especially to Dr. Taylor, but for everybody who's watching. And I hope you have a great rest of your day and stay safe.